Thank you for coming over. One of the main challenges in the pharmacotherapy of Down syndrome is actually that we don't have a lot, if any, papers that can handle this kind of pathology. We have a lot of papers that can show us a little bit of, yes, it shows us a little bit of what is happening in learning disabilities. But learning disabilities do not necessarily include, or sometimes they include, the Down syndrome pathology. So we have a quite limited evidence base. And we have also a clinical polymorphism. As Dr. Katsaru explained to us, there are so many patients, and because we have a genetic syndrome that is quite polymorphic. For example, they have the patients that do have Down syndrome, but with mosaicism. It's not the same thing as someone who has a classic Down syndrome with the triple repetition of the 21st chromosome and with an important intellectual deficit. We have also a limited applicability of diagnostic criteria. We are going to see afterwards that we cannot actually transfer, or not so easily transfer, the diagnostic criteria that we have for Down syndrome from the general population to patients with Down syndrome. And there are the increased somatic and psychiatric comorbidities, especially the somatic ones are quite a challenge. In all the guidelines, for example, the UK NICE guidelines or the German S3 guidelines, medication is always a second-line treatment. The first-line treatment is environmental psychological interventions. Taking that into consideration, we have the target symptoms such as depression, anxiety, sleep, psychotic disorders, management of behavioral symptoms, especially aggressiveness, one of the greatest challenges for the carers and the patients themselves, and the anti-dementia medication, both in terms of the cognitive decline and PTSD and behavioral and psychological symptoms of dementia. In order to be able to prescribe pharmacotherapy in patients with Down syndrome, we have to take the initial steps into consideration. First of all, the evaluation of medical history in order to get an informed prescription of medication. Of previous pharmacological interventions, what has been already tried, the functional analysis of behavior, for example, a sleep diary or an analysis of the aggressive episodes, in what context do they occur. And this will also help us to be able to prescribe less of a medical treatment. And of course, one of the main challenges is the capacity of constant evaluation, especially with patients who do have intellectual deficits. On the other hand, this is one of the problems also with patients with dementia. We cannot necessarily prescribe and then ask the patient if he's okay with the prescription of the medication. The treatment plan should be nevertheless discussed with the patient and the carers, and to the extent that the patient understands what is the meaning of the prescription, he should concur to that, and this has to be kept in the patient file, because most of the medication prescribed is off-label. So there has to be a thorough documentation of the side effects. There is also inconclusive evidence about the altered pharmacokinetics. There has been one or two studies that have actually pointed that perhaps the hepatic metabolism is different in patients with the Down syndrome, but this cannot be held as a default knowledge. There is also the challenge of frequent concurrent treatment with anti-epileptics. So especially for prescription of antipsychotics and antidepressants. Just like the dementia patients, we have to start low and go slow in terms of increasing the dosage of the medication, avoiding the polypharmacy, and then after a stable period of minimum 6 months, a progressive withdrawal should be attempted. In terms of the affective disorders, it is not only expressed through the normal emotional symptoms, what we have, for example, in a major depressive disorder in the general population, but also what we have is more the functional effects of an affective disorder. For example, the behavioral regression, or the social withdrawal, or irritability, aggressiveness, and also injury. So there has been a lot of studies in learning disabilities about the SSRIs. would have a better tolerated profile, especially with antiepileptics. There has been no conclusive evidence in which medication, in terms of all the SSRIs, should be used. There are studies that have been conclusive more about fluoxetine, for example, more about sertraline, but we don't have a standard medication. Of course, tricyclists and some SSRIs can increase aggressive behavior because they can actually increase the anxiety. And tricyclists, they have also to be avoided in terms of the possible cognitive decline they can actually produce. So the combination strategies, for example, antidepressant and antipsychotics, which has been very, very widely used in the clinical practice, especially in nursing homes, it has a very limited evidence base. And this is why monotherapy or a very low combination therapy has to be preferred. In terms of the mood stabilizers, lithium is superior to placebo in LCTs. The problem with lithium, as you may know, is that it has to be carefully monitored, and because patients with Down syndrome do have the tendency to get dehydrated, we have to constantly monitor the medication. Sodium valproate or carbamazepine has been preferred only in open studies, with a very, very small effect size in favor of them in terms of placebo. And of course, benzodiazepines have to be used only in rapid tranquilization, which may actually worsen behavior. And of course, there is the risk of cognitive decline in older adults. In terms of antipsychotics, for aggression, stereotypical behavior, and self-injury, risperidone is the only medication that has been on label for aggressive behavior in dementia and autistic disorders. But we have a very, very limited studies for Down syndrome patients. They have been used, we have used the different antipsychotics, for example, haloperidol, aripiprazole, or olanzapine, which have shown positive effects. There is a poor evidence-based and non-negligible side effects and increased cardiovascular events. Some of you may know that in the NHS they do have, this medication comes with a black line. That means that they have to be very carefully monitored. And sometimes we have seen in some papers that the tapering of antipsychotics, actually the decrease of the dosage, can lead to an improvement of the behavior. One of the challenges, as it was explained beforehand by Dr. Katsaru, is actually the difficulties in staging through neuropsychological testing in dementia patients. We cannot actually transfer the classic dementia screening tools in Down patients. But the UK NICE guidelines actually say that the dementia patients with Down syndrome should benefit from the dementia drugs. The acetylcholinesterase inhibitors, for example, tonepezil, they improve cognitive global functioning. They slow down the cognitive deterioration, but there is actually a small advantage over the placebo. Memantine, there was a big study in the UK some years ago, and it actually showed, despite the promises, no significant effect in patients with DS in a randomized controlled trial. The problem with the study was that it did not differentiate between dementia and not dementia. It was actually prescribed for all patients with Down syndrome. So one of the remarks, the closing remarks of the authors of the study was actually that we have to find a small population that only has dementia and see what actually happens. There is also a retrospective child study from Sweden that actually showed that SSRIs can actually slow the cognitive decline, but this slowing is actually of a modest effect, some months. In terms of the behavioral and psychological symptoms of dementia, there are no specific studies, as mentioned beforehand, and the same treatment guidelines should apply. So one of the big hopes for the pharmacological interventions is the transgenic mouse model of Down syndrome. And there have been even more studies that actually shown a small effects in terms of, for example, the prescription of memantine or the prescription of other substances, for example, vitamin E. But the problem with the study is that limited transferability. What it was beneficial in mice was not necessarily beneficial in humans. So as a small take-home message, that most medication is actually off-label, and it has to be the second-line treatment. We do have to make an assessment of the smart health and side effects of the existing medication. The start low and go slow, taper off principle. Avoid polypharmacy. In terms of the antidepressants, SSRIs have to be preferred over the tricyclics. Mood stabilizers have to be considered. Risperidone is the only on-label medication in depression. And donepezil can be used in dementia, and memantine in behavioral and psychological symptoms of dementia. Thank you very much for your attention.